All right, thank you for joining us. Today we have Angela Trepanier, I think I said that right, who is a certified genetic counselor and a professor in the Center for Molecular Medicine and Genetics at Wayne State University School of Medicine, excuse me, and the director of genetic counseling graduate program at Wayne State. Throughout her career, Angela has worked with various audiences to identify the challenges of integrating genomics into healthcare and working towards developing solutions to these problems. She has over 25 years of experience teaching graduate students, healthcare professionals, and other audiences about medical genetics. For over 8 years, she has worked with the Michigan Department of Health of Human Services and the CDC-funded cooperative agreement to increase appropriate referrals for cancer genetic risk assessment and counseling services through provider and patient education. She has helped develop policy statements and practice guidelines related to genetic counseling and testing, and served on the National Society of Genetic Counselors Access and Service Delivery Committee, which investigates ways to improve genetic counseling at the national level. Angela is the past president of the National Society of Genetic Counselors and the Association of Genetic Counseling Program Directors. She currently sits on the American Board of Genetic Counseling and the Michigan Board of Medicine. So thank you for being here and welcome. I'm going to stop sharing and you're welcome to share your screen.
Thank you. Okay, can you see it okay?
Yeah, looks great.
Okay. All right, well, thank you so much for the introduction. And what I'm going to talk about today is related to the work that I've been doing with the Michigan Department of Health and Human Services on public health strategies for improving appropriate access to clinical cancer genomics services. And the goal of what I'm going to present today is to help you recognize the value of identifying people who do have an elevated risk of developing cancer, and why identifying them and then taking means to reduce their risk can really improve their cancer outcomes and just their healthcare in general. And then I'm going to talk about barriers that we've identified that limit patient access to being able to identify that they have an inherited cancer risk and their access to cancer genetic counseling and testing services. And then I'm going to describe some provider level and public health level initiatives that we've done in Michigan to try to reduce these barriers. And I don't have any conflicts of interest to declare. So just a little background on public health genomics. Usually when you think about public health approaches, you think about things that promote health and disease prevention. And usually they're population-based, so they're really targeting, most of a population. For instance, cancer screening recommendations for breast cancer screening, cervical cancer screening, colon cancer screening. But some do target population subgroups that are underserved. And when we're thinking about cancer genomics, that's what we're talking about. And cancer genomics is an emerging area of public health, and we use it to identify people who have an increased or elevated risk for developing a treatable or preventable condition, such as a hereditary cancer syndrome. And so this is chronic disease prevention. And our program sits in the chronic disease branch of our Michigan Department of Health and Human Services. And it only affects a subset of the population, but it does pose a substantial elevated risk to those people who have an inherited cancer syndrome. And people with inherited cancer syndrome also typically develop cancer at an earlier age of onset. So if there's screening that is normally done for that type of cancer, their age of onset might happen before screening typically starts. So we miss that opportunity to identify their risk. And then for some of the cancers that people may be at elevated risk for, there may be no population screening. And so we're not looking for that at all. And so that's why it's really important to identify people who have these inherited cancer syndromes so that we can provide them with the appropriate management. But you have to have, if you're going to do anything at the public health level, you have to have evidence that identifying the specific condition will actually improve somebody's health. And that's one of the necessary first steps. So in terms of, hereditary cancer targets in public health, there are two evidence guidelines that are the basis for the work that we've been doing in Michigan and that the Centers for Disease Control has been funding other states to do work in since 2008. And those conditions are Lynch syndrome. And in 2009, there was an evidence-based publication called the Evaluation of Genomic Applications in Practice and Prevention guideline on genetic testing for Lynch syndrome. And they recommended through that evidence-based publication that all individuals diagnosed with colorectal cancer be screened for this condition. And that means screening their tumors for some specific features that would indicate a higher chance that somebody might have Lynch syndrome. And the reason why they made this recommendation was that identifying those individuals with Lynch syndrome could actually allow their relatives to be tested for Lynch syndrome. And if the relatives were positive, then they could take cancer prevention steps. So it wasn't about changing the management necessarily at that time for the patient with colorectal cancer, but it was really about recognizing that if somebody did have this inherited condition, their relatives were at risk, and it was an opportunity to intervene with those relatives. So that was published in 2009 and had high quality evidence to support the recommendation. And then in 2005, so before that, there was the United States Preventative Services Task Force published an evidence-based recommendation that said that we should be using family health history to identify unaffected women who had an increased risk for a BRCA, so breast cancer 1 and 2 genes, pathogenic variants, which is another word for mutation. And it was given a B rating, which is a pretty high rating. A is the highest. And so basically this said that there is a reason to identify women who have an increased risk of developing hereditary breast and ovarian cancer associated with BRCA mutations, and that there was evidence to support that you should be doing this regularly. And then the recommendation also said that there was strong evidence that you should not be offering genetic counseling and testing for hereditary breast and ovarian cancer for people who are not at elevated risk based on family history. So there were really two parts of it. So that was published in 2005. Again, a lot of evidence to support it, systematic review, and evidence from the literature. And then it was revised in 2013, and the revision just changed how they recommended that family history be collected to identify people at risk. And then it was revised again in 2019 because up until that point, the recommendation was really for unaffected women using family history to identify if they're at increased risk. In 2019, they also included individuals who had a personal history of or the family history of breast, ovarian, tubal, or peritoneal cancer to the recommendation. And again, it was based on strong evidence. So good evidence that it is important to do this because it can change somebody's health if you identify them and refer them appropriately. And just some background, I'm sure most of you know about this, but what are these conditions and why are they important? Lynch syndrome only accounts for about 3% of all colon cancers, but it's associated with a very high risk of developing colon cancer, endometrial, ovarian, and some other cancers. It's caused by pathogenic variants in one of 4 DNA mismatch repair genes. And it's autosomal dominant. So if a person has it, each of their first degree relatives has a 50-50 chance of also having this condition. And these are just some of the numbers that show how elevated the risks are. There's a lot of variety depending on the gene involved, but just the 2 important points to take from this slide is that the cancer risks are very elevated and the age of onset is much younger than typical for many of these genes. And because of that, it's important to identify people early, and it's important to identify that or to provide screening early. And it's important to recognize that they're at risk for more than one type of cancer. And then just also with Lynch syndrome, colon cancers are more likely to be in the proximal colon versus the other parts of the colon. So you need colonoscopy as the screening mechanism versus something like flexible sigmoidoscopy, or the general population screening guidelines for colorectal cancer give you options, right? And then again, early age of onset. So you want to start screening at a much earlier age than usual. The lifetime risk of developing cancer is up to 80 to 90%, so markedly elevated. And the other thing to consider is that, most people, they have a negative colonoscopy. They don't have to come back for 10 years. There's a really high risk of interval cancers. And so individuals with Lynch syndrome should have repeat colonoscopies every 1 to 2 years. And so that's probably the biggest change, starting earlier, making sure it's colonoscopy, and then making sure that it's done frequently, even if you have a negative one. And then there's some other screening and preventative measures for the other cancers too. And there's different ways that you can identify Lynch syndrome. Traditionally, it was done by high-risk family history. So there was clinical criteria that you could use looking at somebody's family history to see if there was evidence of Lynch syndrome, and then using molecular testing to find out who in the family had that condition. And when we were primarily using the family history mechanism to identify people at risk, then it was important to identify, to educate primary care providers about how you look at family history, what risk factors you're looking for, when you're trying to help them do a better job in identifying who might be at risk for this condition. And then also with primary care, you want to explain to them why it's important to identify this, how management is actually significantly different. But then with the EGAP recommendation, which said that everybody who's diagnosed with colorectal cancer should have screening for Lynch syndrome using one of two different ways, that target audience became the pathologists who are doing the surgeries for colorectal cancer. And so that said, every colorectal cancer should be screened for evidence of Lynch syndrome. And then if it comes back positive, then a referral should be made so that there can be further evaluation and genetic testing to see if the individual has that condition. And then if they do, then letting their family members know so that they can avail themselves of testing. Okay, so that's Lynch syndrome. The other syndrome that we're talking about today is really the hereditary breast cancer syndromes, which started out with just hereditary breast and ovarian cancer being the most common ones that testing was being offered for, but has really expanded to a lot of other conditions as well. In all of these conditions, they're associated with an elevated risk of breast cancer. They're all associated with other specific types of cancer, and they all have different screening and management guidelines. But hereditary breast and ovarian cancer syndrome is the most common one, and the one that the USPSTF guidelines were first developed to help identify. And it's associated with breast cancer, both in males and females, ovarian cancer, prostate cancer, pancreatic cancer, melanoma, and some other cancers. And, again, this is a subset of the population, not everybody. About 3% of all breast cancers are due to BRCA1 or 2, and then 10% of all ovarian cancers. And like I said, there's a significantly increased risk of breast cancer. There's an earlier age of onset. So again, initiating screening at an earlier age, increased risk of specific cancers depending on the syndrome, and some have more common tumor characteristics. And then people who have these conditions have a higher risk of developing 2 or more primary cancers than people in the general population. And then these are just some of the cancer risks, just to show how elevated they are compared to the general person, and what some of those risks look like. The other concern with hereditary breast and ovarian cancer is that it's present in about 1 in 400 people in the general population. But if a person is of Ashkenazi Jewish descent, then the prevalence is 1 in 40. And there are 3 common pathogenic variants in the BRCA1 and 2 genes that account for most of the changes in people who are of Jewish descent. But what it means, the bottom line, is that ethnicity, if somebody is of Jewish descent, it increases your suspicion of hereditary breast and ovarian cancer, even with less family history than somebody who doesn't come from that background. And just like with Lynch, screening is different. It starts earlier. We use different modalities, so not just mammograms, but MRIs as well. It's more frequent. People can avail themselves of preventative measures. They can decide to have prophylactic mastectomies or have their ovaries removed, their tubes and ovaries removed as options. And because there's other cancers, for each of these syndromes, you have to be aware of what are those other cancers and what screening should somebody have based on the diagnosis that they have. And again, it's important to communicate these differences to providers, because one of the biggest barriers that we hear from providers is that, yeah, I could identify somebody with this condition, but if it's not going to change anything, then why would I do it? And so making sure that providers and patients know that there could be big differences in terms of how they're managed is an important part of trying to increase awareness and increase utilization of cancer genetics. And then there's also differences in terms of treatment. So having a BRCA mutation can impact cancer treatment. And some people have testing mainly for this reason. So in 2018, the FDA approved olaparib for the treatment of HER2-negative metastatic breast cancer in women who had an inherited mutation in BRCA1 or 2. And so if somebody had HER2-negative metastatic breast cancer, that would be an indication for doing genetic testing for BRCA1 and 2 just for treatment purposes. even if there were no other reason that the person wanted to proceed with that. And then the FDA had previously approved olaparib for the treatment of advanced ovarian cancer in people who are BRCA positive, but extended the approval to women with recurrent ovarian cancer regardless of their BRCA status. But just the point to drive home is that, these developments, in addition to that expansion of the USPSTF guidelines to not just cover people with a family history, but people with cancer, made it important for us to include not just primary care physicians in our education to try to improve appropriate access to genetic counseling and testing, but also oncologists, surgeons, nurse navigators, pathologists, and others. And then in terms of, why do we want to do this? Why are we looking at these two conditions, which, are not uncommon, but are not as common as, your population-based cancers? Why should we do any strategies to really focus on these? And the bottom line is that there's strong evidence to support that there's value in identifying people at risk for these conditions. And there's also strong evidence that these conditions are currently not being identified. And like I showed, management is completely different. So it's so important. If you don't identify the individuals at risk, you're going to miss an opportunity for cancer prevention, or at least to catch cancer at an earlier, more treatable stage. And even though it's just a subset, it's actually a pretty significant subset of people who could be affected with these conditions. And if they're not identified, then they miss out on an opportunity to initiate that appropriate cancer screening, which, again, could detect that cancer at an earlier, more treatable stage. Or like with colonoscopy and polypectomy, it could actually prevent cancer from happening. Or if they have a prophylactic surgery, it can prevent cancer from happening. And they miss out on that chance to choose whether or not they want to do some sort of preventative measure if we don't identify that they're at increased risk. They might not be offered the appropriate treatment if they have, for instance, metastatic cancer, if we don't know that they carry a gene mutation. And they lose the opportunity to help their family members identify that they are also at increased risk and might have some options available to them. So those are all the things that we miss if we don't do these things. And there's, like I said, there's strong evidence to support that we should do this. So why is there a lack of access to cancer genetic counseling and testing? What are the barriers? And I really like this one paper that was a systematic review that looked at primary care providers' perceived barriers against provision of genetic services, because it really helped lay out a lot of the challenges. And this systematic review found 311 unique barriers. They fell into 38 categories, and there were 4 major themes. And that included deficits in their knowledge, skills, competence, comfort, and their ability to perform certain tasks associated with risk assessment, like taking a basic family history and knowing what to ask. The most common barrier was just lack of knowledge. Genetics is changing all the time, and it's not something that people think about. Primary care providers think about that they encounter in their practice probably more regularly than they know, because they're dealing with things like, diabetes, high blood pressure, your common chronic conditions. So there's general lack of knowledge, and there's a lack of confidence about how to counsel patients, even if they do identify that a patient's at risk. And in terms of lack of confidence, it was lack of confidence in ordering and interpreting a test. There were barriers related to how you even perform a risk assessment and how you identify high versus low risk patients. Lack of access to current information and limited awareness of educational resources. And there were ethical, legal, and social barriers that they were concerned about, like the potential for the patient being more anxious and psychological distress around genetic testing. And just as a side note, we did a project here where we reached out to individuals who, based on our cancer registry, had made a diagnosis of breast cancer before the age of 50, or ovarian cancer in anyone, or male breast cancer, to let them know how many patients in a certain period of time they'd seen who had those types of cancers, because those individuals would have been eligible for genetic counseling and testing. And so we reached out to them to say, hey, did you know that you saw this many patients? They were at risk for hereditary breast and ovarian cancer. So if you didn't refer them, you should refer them for cancer services. And then we followed up to see whether they looked at those reports that we sent and what their takeaways were. And one of the GYN oncologists we talked to said, Oh, yeah, I never offer cancer genetic counseling or testing because I think that would stress my patients out too much. And this was a person who was seeing basically all the ovarian cancer cases in one particular region of Michigan because he was the only provider. And so just, that one person being worried about that and then making a uniform decision not to offer that testing then potentially affected all the women that came to see him for their cancer diagnosis. So things like that can actually have a big difference in access. And then clinicians said they were also worried about the chance of unanticipated findings. And they also feared insurance discrimination, which was the second most common concern they had. And then there were 40 barriers related to healthcare systems. And the biggest one was lack of access to genetic services. People were worried that there weren't enough genetic counselors or specialists, and they didn't know how to reach them, even if there were some in their area. Some talked about challenges of even just obtaining a consultation, even when they found out who to reach out to. And living in a rural location, as you can imagine, played a major role. Although the one thing that has come out of the pandemic is just increased telegenetic services and telephone genetic counseling services, which has increased access. So that's a positive thing that came out of the pandemic. They talked about time as a barrier. It takes time to collect family history, and they don't really have time to do it since they spend so few time and see so many patients in a given day. The time that it would take to explain genetic test results. They perceived their role as a barrier. Some felt it was not their role to deliver genetic services, and some weren't really clear like what they should be doing. And then they were worried about cost to the patients, cost to them in terms of time, and cost for testing. And then they also didn't really understand that there could be a change in how a patient was managed based on genetics. They felt like you'd get information and then you just be anxious about it. There's nothing you could do about it. So really lack of knowledge. And then there was also this misperception that there's really no therapeutic interventions available to those people at increased risk, like I just said, and so there would be no change in management. They felt like there was a lack of guidelines and insufficient evidence. And, again, it wasn't that there aren't any guidelines, it's just that they weren't aware of them. It wasn't part of their daily practice to look at that kind of information. And then they'd also heard about limitations of genetic testing, so ambiguous results or inaccurate results. And so that also led to concerns about offering their patients this kind of service. And then in the 4 largest US studies, the most common barriers are really lack of knowledge, challenge to access, perceived lack of therapeutic interventions, fear of insurance discrimination, lack of guidelines, or lack of confidence in making genetic referrals. So those are the things when we were thinking about what we wanted to do in Michigan, those were the things we were thinking about. These are the things we likely need to address to make any meaningful impact in changing the rate of referral. And so the activities that go along with that then are to develop educational opportunities using best practices in education, promote awareness, let providers know that there are practice guidelines, that there are care guidelines, provide point of care risk tools to make it easier to be able to assess risk of cancer, develop a variety of educational tools, pay attention to the system level issues like access, and help people recognize how to access services. Right, so that's the background, that's the issue that we're dealing with. In the Centers for Disease Control and Prevention, Genomics and Precision Health Initiatives, since 2008, the CDC has been funding select states to build capacity for cancer genetics risk assessment programs in public health, and focusing in on the hereditary breast and ovarian cancer and Lynch syndrome, because there were those 2 evidence-based guidelines that showed us that there is strong evidence that identifying these conditions actually does make a difference to patient care. So the first program was initiated for hereditary breast and ovarian cancer. That was the first guideline that came out in 2005, and that program was initiated in 2008. And there were 2 funding cycles from 2008 through 2014, for which they just focused on hereditary breast and ovarian cancer. And then in 2014, which is about 5 years after that EGAP recommendation for Lynch syndrome came out, Lynch syndrome was added to this funding cycle. And Michigan has been funded under one of these cooperative agreements since 2008. Now, unfortunately, this year we would have reapplied for the upcoming funding cycle, but these grants are not being offered for the next year. Hopefully they'll initiate them again in 2023, but there was some sort of, I don't know, issue at the Congress level that prevented the authorization from happening for these grants to be funded for the next cycle, but hopefully it'll change. And then the CDC uses something called the Science Impact Framework to trace whether or not the programs that it's supporting, these public health genomic programs, are actually having an impact on preventing hereditary cancers. And so I'm going to talk about some of the strategies we've used in Michigan to improve access, but I'm going to talk about them in the context of thinking about this framework, because you have to, anytime you do any sort of public health initiative, it's important not just to like do things, but actually check and see if they're having an impact and what kind of impact they're having. And it's not just because it's a funded activity, it's because at any, public health, people are busy and you want to make sure that you're putting your effort into things that are actually making a difference. And so the goal is that I'm going to tell you some of the strategies that we use so that you can think of some strategies that maybe you could adopt or adapt in Indiana. And then this is just a picture of the CDC's framework, and I'm just providing this in the slides so that you have this information, but it talks about all the different ways that they think about the impact of the work that's being done in public health genomics. And so they look at dissemination, creating awareness, catalyzing action, affecting change, and shaping the future. And I highlighted some of the strategies that you might not necessarily think of, but that are strategies that can be really helpful in this work above and beyond the typical things you think about when you're doing any sort of implementation work. So, in terms of dissemination, we always think about, oh yeah, I publish in journals, present at professional meetings, but social media is actually a really powerful way to get messages out to a lot of people very quickly. So that's a strategy that's part of disseminating. Might not sound very scientific, but it's a good way to get information out there, not just to lay audiences, but to providers. Creating awareness also, you think about continuing education, providing resources, developing curriculum, but also electronic communications. The CDC has listservs, they use social media regularly. They use the news to talk about different issues, and then also a system of rewards. So rewarding, policymakers, institutions for, adhering to best practices when it comes to cancer genomics. So things like that can also help create awareness. Catalyzing action, partnerships, and collaborations are a key aspect of all CDC, initiatives, technology creation. Supporting congressional or statewide bills, or which is always difficult. Like when you're working for a state agency, you can't really do that directly, but knowing what information is like what bills are out there and which ones you could support. And then affecting change through lots of different ways, not just building public health capacity, but also looking at legal and policy change, registries and surveillance, and also really considering cultural, social, and economic or behavioral change. And then finally, shaping the future is coming up with new strategies and implementing new programs that are shown to be effective. All right, so coming back to Michigan, what have we been doing? Our Michigan is to protect, preserve, and promote the health and safety of the people in Michigan. And our mission does include that we focus on genomics, as well as other aspects of public health that you might consider pretty routinely. And then the vision of Michigan is to be a national leader in the design and implementation of health strategies that are culturally responsive, and that includes genomic health strategies. And everything we do is based on the 3 core functions and 10 essential services of public health. And so what that is we assess what's the problem we're trying to address, it needs to be something measurable. We develop policies, those are the strategies to fix the problem. And then we do assurance, which is investigating whether the things that we've done are actually making a difference. So in terms of assessment, the question in Michigan started out as, do Michiganders have appropriate access to cancer genetic services as defined by those evidence-based guidelines? So we're looking specifically as, do they have access to services if they're at risk for hereditary breast and ovarian cancer and Lynch syndrome? And the first step in knowing whether or not it's an issue is being able to actually measure to what extent do people have access. So back in 2011, Michigan first added questions to the Michigan Behavioral Risk Factor Survey to identify individuals who met those USPSTF guidelines for hereditary breast and ovarian cancer. And so because it was 2011 and this was the first or second funding cycle for the CDC, they were only covering HBOC, so it was focused on that condition. And then later they added questions related to Lynch syndrome. So we've been following it since 2011 for hereditary breast and ovarian cancer. And in 2018, which is the latest data that we have, about 11.7% of female respondents had a significant family history of breast cancer that met guidelines or ovarian cancer. And 13.9% met USPSTF specifically, but only 10% of those individuals who met those guidelines had actually had genetic counseling. About 23% did report, though, that a family member had had genetic counseling. And that was an improvement from 2011 up through 2018, but clearly there's still a lot of progress to be made if that's the percentage that's getting services. It means that a majority of people are not getting those services. And then, like I said, data on colorectal cancer is also being collected now through this Michigan BRFIS survey. And then these are just the questions that were asked on the survey in 2020. And these questions have changed over time, but they're here for your reference. Then the other unique way we've been able to assess access to cancer genetic services is that because we had this cooperative agreement and funding, we were able to establish a unique database that provides tracking of the use of cancer genetic counseling and testing services for actionable genes associated with hereditary breast and ovarian cancer and Lynch syndrome and others. So with our funding, we were able to partner with our clinic partners in the state. And this diagram shows you that each year how many different clinical partners we partnered with. And you can see that in 2013 it was 17, it went up to 20, that's the highest, and then it's dropped in subsequent years, although it's waffled a little bit. And it's because it takes some time to, what happens is that if somebody has genetic counseling and testing at one of these clinics, then a form is filled out and submitted and then entered into this database. And so the purpose of this database is to identify who's having genetic counseling and testing, what are the characteristics of those individuals in terms of family history. We also look at race, ethnicity, area of the state they live in, and other factors, who referred them. And then what are the outcomes? Do they have testing? Do they not have testing? It's all de-identified, so we don't have access to names and contact information. So it's not meant to be a way to reach out to those individuals again. But each center has their own data to do whatever they want with. If they want to do some research studies on that data, and some of those studies have been done. And the name of it just changed. It was first just the BRCA Clinical Network database because it was only collecting information about visits for hereditary breast cancer and ovarian cancer. But once we started including Lynch syndrome and other cancers, and this was really when panel testing became available, then it expanded to all people coming in for hereditary genetic counseling and testing for hereditary cancers. To date, over 24,000 unique patients have been entered into the database. And it's a great resource, but there's been lots of implementation challenges. Even though sites get funding to collect the data, it's still time consuming. So it's a really wonderful resource. It's just not something that every state's going to be able to put together. And even when you have it, it's sometimes hard to keep the enthusiasm for doing it going. But it's been a great source of data. And this is just a data shot from the data collected through the Hereditary Cancer Network database. And so you can see it shows the number of patients, visits and testing starting in 2009 through 2019. And you can see that the number has gone up substantially. And that's despite the fact that the number of clinics participating to submit data has gone down in some years. So that's good to see. There's more awareness. And this is really what we're trying to measure is, are the awareness things that we're trying to do, are they having an impact on how many people are getting referred? And then we started looking in 2016 and 2019, what type of service delivery model was being used. And I don't have the data now, which is going to look substantially different, as you can all imagine. But up until 2019, most people were coming in for in-person genetic counseling with the subset coming in for telephone genetic counseling. But we are sure that that has significantly changed, just knowing what the practices are in our clinics in Michigan. And then this is just another sample report. This is a data report looking at breast cancer. And the 41,000 white women in Michigan were diagnosed with breast cancer. That comes from our cancer registry. So that was between 2014 and 2018. And then also we have the number of Black women in Michigan diagnosed with breast cancer in that period of time. And then we looked at the number who have received genetic counseling and testing based on ethnicity. And so we look at that data to see, like, are we reaching are people getting access to genetic counseling and testing? How many people are getting access? Is that number or is that proportion increasing over time? And are there specific groups that are getting less access than other groups? Because if that's the case, then we need to do something about that. And even though the difference might not look that different, it is a statistically significant difference based on race in terms of who's getting access to genetic counseling and testing. Okay, so that's just a little bit about assessment. What about policy development, those strategies to fix the problem? And so we're going to talk about the efforts that we've made to inform and educate and empower providers, and then to also mobilize community partnerships. And when we're thinking about who we're trying to inform, educate, and empower, again, it's a pretty broad swath of people in Michigan. It's primary care providers, surgeons, oncologists, nurses, nurse navigators, but also the public and lots of different aspects of the public. And in terms of our activities, we have a web-based module on hereditary cancer that's available for CME and CNE credit. We've done many, many targeted educational programs, and we have lots of point of care tools, and we have lots of patient resources. And just to give you a flavor for each of these things, one thing that we've had for, I think it's been about 6 to 8 years now, is an enduring CME module with free CME that's on demand. Again, it's free and it has targeted learning objectives that was developed by Jackson Laboratories, the Michigan Department of Health and Human Services, and the Centers for Disease Control, and then the health departments in Oregon and Georgia that were also funded by the CDC. And it's in its 4th version. If you take it, it's for 2 CME credits. Interestingly, over the years, it's mostly been female participants who have been taking the CME. I don't know if that's because, I mean, this covers not just HBOC, but Lynch syndrome and other cancer syndromes, but I don't know why that's the case, but it's been that way for at least the last 5 or 6 years. And the objectives are really to help clinicians determine if a patient's a candidate for cancer genetic testing, deliver pretest counseling that's appropriate to the patient, select the best genetic test, interpret the results, and identify patient management. And our philosophy in Michigan is that there are cancer genetics providers who have expertise in that area, but we want to empower people who feel like they have the tools to do cancer genetics risk assessment and testing to do it. So we educate them and then ask them to self-assess whether or not they have the skills needed. If they do, then they should be offering this to their patients directly. If they don't, then they can refer to a provider who has more expertise. So we've had that enduring program, but we've also done lots and lots of targeted education programs. We use all different types of formats. We did a needs assessment, and it was all across the board in terms of what people wanted in terms of format. Some people wanted a full day, some people wanted a half day, some people wanted weekdays, some people wanted weekends, some people wanted short presentations, some people wanted just recorded on demand activities. So it really varied. And so the programs that we've developed have done all of those different things for different audiences. We record everything that we do now because we know that sometimes people think that they're going to be able to come to a presentation, then they can't come. So it's available then online, usually not for CME, but at least it's available. And it really has expanded the reach of a lot of our programs. The limitation is that there's, primary care in particular are very busy, and they have lots of different, needs in terms of education. And cancer genetics doesn't always rise to the top. So oftentimes we get maybe 25 or 30 people, but the more we do, the more different people we can reach, the higher the likelihood that somebody's going to get the information and be able to use it with their patient population. So we just go into any educational activity recognizing that we're not going to get hundreds of people, but if over time we can get hundreds of people, then maybe we'll make an impact. And again, we targeted a variety of audiences, and whenever we develop some sort of education program, we really think about, well, what does that specific audience need to do? We bring in providers that are peers to that particular audience, so they can hear from their own people in their own profession. And we work with a lot of different organizations to develop education that will fit the needs of their particular organization. And that includes like the BCCCMP program, the cancer registrars, we've done lay audiences, and also the health plan administrators. We've done education for them too, to help them understand, when should you be authorizing genetic counseling and testing. And then we've also created some targeted topics, focused topics, depending on current issues in genomics and medicine. So we did a session on improving access through alternative service delivery models. We did it in 2019, and it just happened that we did it right before the pandemic, and we had done a pre-assessment to see how many people were using alternative service delivery models. And it was, it was fairly low. And then the post was after the pandemic, and it was much higher. We have done a session on strategies for increasing cascade screening, and then we did a session on facilitating conversations about hereditary cancer with underserved populations, with the increased work being done on DEIJ and health equity. We bring in lots of different types of speakers. We try to identify champions. We utilize peers or professionals from a variety of different institutions so that people can hear from people that they might respect, or from institutions that they are very familiar with. And then we try to bring in people who bring different perspectives to the presentation as well. And the more people that you can bring in from different institutions, they can then bring in their staff from their institution to attend these. So the wider you can reach out, the more likely you are that people are going to be able to access your presentations. And then again, lots of partner organizations. And then we've also developed a lot of different resources for patients. We have a lot of data briefs for people who want to look at, what's the impact that we've actually made. We have a hereditary cancer toolkit, and then resources for providers. And just some of our resources include a hotline to call with questions about hereditary cancer, because we felt like there's just some people who just want to pick up the phone and call, but there's really not that many people who want to pick up the phone and call. So we have a hotline. We do get calls. We do not get that many calls, but it's available because not everybody feels comfortable enough to use a website or to email. We have a variety of risk assessment tools, referral tools. We have a health plan policy. We have lots of our education tools that I just talked about, lots of resources, informed consent tools, and lots of other things. And I'm just going to show you a few of these and why we developed them. And so one of the things that we developed that originally started out as shaped like a pregnancy wheel. It was a handheld cancer risk assessment tool that a provider could pull out of their pocket in clinic to do a quick risk assessment for criteria related to HBOC and Lynch syndrome. And so we felt like if you give people point of care tools, something they can just pull out when they need it, then it's really much easier for them to be able to assess somebody's risk of cancer. So it started out as a handheld tool. And then about 3 years ago, we updated that tool and made it an online tool. And it's you can see a little screenshot of it here. There's a series of questions that providers go through with their patients to determine if the patient's at increased risk. It's based on NCCN guidelines. We update it regularly. That's the advantage of it being online. It's not that hard to do because NCCN changes pretty regularly. And some questions, if you get to a question where you get a yes, then you can stop asking questions and just make the referral. So we tried to make it as simple as possible and take as least time as possible for the provider. And when we tested it out with audiences, some people did ask for a paper form, so we do have a paper form that they can download as well. But this is just a way of trying to improve a person's ability to assess risk and do it efficiently. And then the other thing you always hear is that, well, we don't know where are the genetics professionals. How do we identify where they are? So our Michigan Cancer Genetics Alliance has a directory of cancer genetic service providers that's updated yearly. And this is a provider directory that includes all the providers in Michigan. And they are designated as either board certified or board eligible genetic counselors, physician board certified in medical genetics, or a genetic counseling clinic nurse or advanced practice nurse in genetics. credentialed through the American Nurses Credentialing Center, or they don't have any of those credentials. So you can see whether they have the credentials, and then you can see all the providers in Michigan. And we reach out every year to make sure that it's an up-to-date resource and it's available online. And then we also have a link to the National Society of Genetic Counselors Find a Genetic Counselor tool on that same page. But again, if people can't find where the providers are, then let's give them a resource that shows them where they are. And then to address the issue, like we don't know how to have conversations about a referral to genetic counseling services, we developed this 4 steps to making appropriate referrals that has specific language on the second page about things you can say to your patient to explain why you're making this referral and what's going to happen in genetic counseling. And all of these tools are usually developed by a team of individuals from different institutions who provide feedback and then reviewed by a bigger group of professionals before they're finalized. We also then have a bunch of informed consent tools. Michigan has an informed consent for genetic testing laws, so we have a brochure that we just updated related to that. But we know that audiences like lots of different formats, so we also have a YouTube video about informed consent for genetic testing. And then we just worked with a public health student at the University of Michigan to develop a comic on genetic testing. And so, the goal is that we're providing tools that might meet the needs of various audiences and different needs or different desires in terms of how to get into education. And then, in terms of policies, often you have to change policy to make any sort of notable system change. So that's something we've also worked on. And one of the first ways we worked on policy was to include genetics objectives in the Michigan Cancer Plan. And so this is from the 2020-31 plan. We have 3 cancer genetics objectives. One is to increase the % of adults who report being asked by their healthcare provider about their family history. One is increasing the % of cases in the cancer registry that have family history recorded. And then the third one is to increase the proportion of those diagnosed with colorectal cancer who actually receive screening for Lynch syndrome, which is related to that EGAP. And so this is, when you put it in your cancer plan, when you have measurable objectives, it just provides some accountability for your state to try to meet these objectives. And then we've also worked with the cancer registry to capture family history, genetic testing, and Lynch syndrome screening. So there was some policy change with what was being collected for the registry. We've been working with health plans to educate them about cancer genetics evidence-based recommendations through tools and education. We've given them awards if their policies are in line with evidence-based guidelines, so that recognition. We've been keeping abreast of legislation that could have an impact on cancer genetic services, like genetic licensure, genetic counselor licensure, and then genetic counselor recognition. And then in terms of insurance policy updates in Michigan in particular, Medicaid would not pay for genetic counseling services because Michigan genetic counselors were not licensed until April this year. But once they realized that licensure legislation had been passed, they actually approved billing genetic or paying for genetic counselor services. Their change in their policy went into effect before licensure actually became available. We had to wait till we got licensed to do it, but now genetic counselors can bill Medicaid if they're licensed. So it's just an example of how a policy change was made, and that policy change can potentially impact access. And then just, all of this involves mobilizing partnerships with lots of different organizations that I've already mentioned, but public health departments, healthcare provider groups, institutions, universities, advocacy organizations, other CDC-funded states, groups like FORCE, which is a national advocacy group, Jackson Labs, which does education, national evidence-based guideline groups. All of these partners are important in making any meaningful change. And then, when you've done all of these things, you obviously have to evaluate to see if it's making any difference, and you need to constantly evaluate and then make changes if things aren't being impacted in the way that you hope they are. And so we evaluate through our BRFIS and through our HCN database. We look for changes over time, and we look at policy changes and their impact. So for instance, looking at how many health insurance plans policies were consistent with evidence-based guidelines. We've tracked that at 2 separate occasions, 5 years apart, to see if there were differences, and there were. We look at learner evaluations from education events to see if they've learned what we hope they learned. It's not the same as measuring whether they're doing it, but it's a one step in the right direction. We look at whether people are actually utilizing the things that we create. I mean, just because you make it doesn't mean people are going to come use it. So that's important to do. And then we assess the resources that we've used from the target audience's perspective and make changes as needed. So to summarize, although people at risk of hereditary breast and ovarian cancer and Lynch syndrome only make up a subset of the population, there's lots of evidence to support that it is important to identify those individuals, but help is needed in this area. So taking some sort of statewide initiative to help could make a difference. And it seems to have made a difference here. And you have to recognize the barriers to access in your particular area, and then develop strategies that are related to what those barriers are, so really targeted. And groups like your group are great places to start because you're already interested in reducing the risk of cancer overall, and you already have a lot of partnerships that could help get this work done. And all of this could result in better access to cancer services, cancer genetic services for your population in Indiana. So I know that's a lot. I know I talked fast. What questions do people have?
Thank you so much, Angela. It was really a wealth of knowledge in the best way. And I think you've done some amazing work and with other stakeholders in Michigan. So, but we do have a couple questions in the chat. Is your hotline for providers or patients? And is that funded by grant dollars, and who answers it?
Yes, it's for providers, patients, whoever wants to call. It is funded by our grant dollars. And what was the other question? Oh, who answers it? It is one of the staff members. So our direct staff is Dominic Smith, who directs our program, Mara Carr-Meckelingag, Jessica Pritzler is an epidemiologist, Erica Doran is an education specialist, and then Beth is another epidemiologist. So Dominic or Mara Carr or Erica usually answer the phone. But like I said, we don't get that many phone calls, and it's forwarded to their phone. So somebody gets, somebody has chosen to get those calls. It's not staffed 24/7 because there's only those people that are doing it. But they usually answer within 24 hours.
Thank you so much. I know you said that's funded by grant dollars, and I know you mentioned earlier that there's going to be a gap in funding because of things happening at the federal level. Will that impact how this system is kind of functioning?
Well, luckily, we'll have some carryover dollars that will hopefully get us through the next year. We're not going to be collecting any data for the database in the next year because that requires funding for all the sites to actually fill out the forms so we can implement the data or input the data. So we're not going to be able to do that. We're pausing that. But we have enough carryover dollars to do some of the other things that we're doing, like the education we'll continue to do. We'll continue to maintain the websites and all the resources on the website, and some of the policy things that we're working on.
Awesome. Thank you. Well, I don't see any more questions in the chat, but again, I thank you so much, Angela, for being here, and we'll be so excited to share this presentation because it was so many good slides in it, and we do have the slides to distribute afterwards. Angela's been gracious enough to share those, so we will do that. So thank you again for being here today, and we really appreciate all your time.
And then just one thing I wanted to add, when I was talking to the CDC about the fact that I was doing this presentation, they were like, well, that's interesting. We've never heard from Indiana. So when and if this funding becomes available again, I wouldn't hesitate to think about maybe having your state apply for such funding. If this is an interest to you and you have a group of people who really might want to drive this kind of work, the CDC is also always looking for new partners. I mean, it really behooves them to work with as many states as possible. So it's just something to consider. And if you did have questions about doing that, you could reach out to us at Michigan and we could walk you through kind of the processes. And I'd connect you with somebody who knows more about the behind the scenes that I do, but just something for you to consider. And
yeah,
any of the resources that we have are available, so you can use any of them that you want, of course.
Yeah, definitely. We, as you were presenting, our early detection committee who put on this series, I think there's a lot of points and things that we could potentially pick up as our own project. So definitely excited to explore that. So thank you so much.
Thank you.
Thanks, everyone. Bye-bye.